Welcome to the Procedural Safety class. My name is Irina Yudin, and I will be your instructor today in the classroom and throughout the electronic tutorials. In the process of creating this education, I have had a very good fortune to work alongside the Procedure Center staff, to observe and to learn their best practices to maintain procedural safety. And I'm very excited to share that with you today and to try to raise our awareness of the importance of maintaining safety during our common bedside procedures. Nurses have an incredibly powerful role when it comes to patient safety. This is particularly true during times of increased risk, such as invasive procedures. So we will spend our time talking about various procedures and focus on key indications, standards, and behaviors that have been proven to provide your patients with the best possible outcomes. Let's start by reviewing our course objectives. The first one we'll cover in detail during the first tutorial is about connecting procedural safety standards with the Joint Commission National Safety Goals. Secondly, we will look at each procedure and discuss pre, intra, and post-procedure care and monitoring for those procedures we do commonly in ICU setting. I would also like everyone to come away from this experience with a well-developed knowledge of our unit's procedure card, its inventory, and uses. We will work on developing competency in setting up and maintaining a sterile field, as well as establishing competency in sterile dressing changes. I hope you'll enjoy this interactive learning experience. Now for the schedule. From start to finish will be 3 hours in length. During this time, we'll fit in one break to help you keep fresh. We'll do pre- and post-knowledge quiz to measure what we have learned as it relates to common bedside procedures. We'll complete each of the 8 e-tutorials that will represent the majority of the education, followed by interactive discussion to review a key concept from each lesson. Before we launch our first tutorial, let's take it offline and do our pre-quiz. Let's begin with Lesson 1, Standards of Practice. These standards are fundamentals of procedural safety and should guide your practice with each and every procedure. Now, some of the guiding principles of procedural safety are embedded in Joint Commission National Safety Goals, as mentioned a few minutes ago. Let's review the goal statements that target procedural safety. Implement evidence-based practice to prevent CLABSI. Implement evidence-based practices to prevent surgical site infections. Conduct a pre-procedure verification process. Conduct a timeout before the procedure. The first 2 statements deal with preventing infection, and we shouldn't underestimate their importance. There was an article in August edition of Nursing 2012 titled Breaking Sterility, dealing with the procedural violation in healthcare. I found 2 really good takeaways from that article. The first was around the serious harm to patients when a break in sterility occurs. The data states that each year, 1.7 million patients acquire healthcare-associated infection, or HAI, and almost 100,000 die as a result. It also states that at least 1 in 5 of these infections could have been prevented. Of all the patient safety issues we confront as nurses, the HAIs are considered to be one of the top 10 most common causes of death. Of these infections, 35% are CODIs, 20% are the result of surgical site infections, and 50% are due to pneumonia and bloodstream infections. Now let's pause for a minute and think about our MICU population. We have incredibly vulnerable patients that are at high risk for these conditions. The other takeaway was about working as a team to ensure compliance to safety standards. The article tells a brief story about a student observing a surgical resident in the OR that breaks sterility and the uncomfortable feeling the student has anticipating a confrontation with the resident. It is a real setup for ethical dilemma. The article demonstrates the need to be supportive to one another to ensure the best practice. The situation was resolved with a calling out a break in sterility rather than a person, and offering to provide a new pair of gloves to support patient care. The student called out to the resident, "What size glove do you wear?" The doc said, "Why?" "I saw you touch the chair with your glove and wanted to give you a new pair." And the doc said, "Size 9, thanks." Supporting the right behavior doesn't have to be confrontational, but we do have an obligation to be present for the entire procedure and participate in the care and monitoring during these interventions. Every procedure should begin with common safety considerations and additional ones that are focused on a specific procedure. Let's run through a list of general safety considerations for each and every procedure. First, relevant past medical history. Know your patient and what might place them at increased risk. Team up with the proceduralist and communicate this information as needed. Coagulopathies. Make sure you have taken appropriate steps to mitigate bleeding risks. Allergies, particularly to any antibiotics and anesthetics. Credentials. As nurses, we have an obligation to check the new innovation database before each procedure to ensure that every provider doing the procedure is credentialed to do so. If not, they must find a credentialed practitioner to perform or supervise the procedure. Patient teaching. Oftentimes, we're pressed for time in urgent situations, so try to roll up the teaching with the consent process, but don't overlook it. Informed consent. The procedures require consent. The medical doctor performing the procedure is obligated to provide indications, risks, and benefits of the procedure. The nurse is responsible for confirming that they understand these and are in agreement to proceed. This is a good time to make sure they don't have any additional questions that can be answered by nurses or doctors involved in the procedure. Universal protocol. Always initiate a timeout. Open up CS link and follow the steps in a documentation. I really want to emphasize the importance of calling a timeout. This 2-minute protocol creates safety. It gives everyone in the room an opportunity to stop and focus on whether we have everything we need in place to proceed, that we're doing the right procedure on the right patient, and everyone in the room is comfortable proceeding. I can't tell you how many times that this moment has revealed critical information that has led to pause for corrective action. We're obligated to perform this with every procedure as a team. This is a national standard of care, and it would be reckless to omit this from your procedural safety process. Once these steps are taken and you're ready to proceed, infection control should become a priority. Barrier precautions such as hats, masks, gown, and eye protection should be worn. Masks should always cover nose and mouth, and hair should be tucked under the surgical cap. Prepare the sterile table and keep door closed to minimize foot traffic into the room. Have you ever noticed that when procedure center comes to the unit, they always close the door? And before offering lidocaine, be sure the top is cleansed with alcohol pad and not offered over a sterile field. Later in this tutorial, we will review specific behaviors to maintain sterility while setting up and maintaining a sterile field. Let's review some standard intra-procedural care and monitoring consideration. Make sure your hands are washed and you're appropriately dressed for the procedure. For example, when a central line is being placed, everyone in the room needs to be wearing a hat and a mask, not just the individual doing the procedure. So be aware of what protective dress is required during the particular procedure and do your part and maintain safety. Make sure all necessary equipment is set up and functional. Always use a procedure cart. Unanticipated items will be close at hand. Maintain a sterile procedure as required during all assists. Remain in the room during the procedure to ensure safety and sterility. Anticipate monitoring equipment and set it up before procedure. Now, let's review standards for post-procedure care and monitoring. Be sure to have a good working knowledge of the procedure and your patient's individual risks, so you can manage and monitor the expected results along with any risks and complications. Be proactive in managing patient-specific risk. Communicate any of the concerns with your medical doctor colleagues, so you can prepare to manage them together. assess for complications at appropriate intervals, and report issues as needed. These pre-procedure, intra-procedure, and post-procedure guidelines are essential standards of care we need to observe with each and every procedure to ensure the best possible outcomes for our patients. It is a simple matter of understanding the procedure and patient's individual risks, observing basic safety concerns, respecting the patient's need for procedural preparation, anticipating needs and issues before, during, and after the procedure, and communicating well as a team to provide the safest care possible to your patients. Now that we have covered general standards of care, let's review our procedure card and how it can be used as a tool to support these standards. The card itself was designed by Dr. Killu from his work in the Procedure Center. It has been adapted to support the common ICU bedside procedures. It consists of 6 drawers and 1 side door. We'll briefly review the contents in a minute. The card itself is checked and maintained daily by our NCT and monitored weekly on Thursday night by the charge RN to make sure the card is stocked and ready to go. Drawer 1. The main items here are gloves, steri strips, skin marker, alcohol pads, chlorhexidine scrub, dressing materials. Drawer number 2 has various needle sizes, flush solutions, sutures, syringes, and tape. Drawer number 3 has various angiocat sizes, decanter, scalpel, staple remover, pressure tubing line, tourniquets, scissors, chest tube clamp, 3-way stopcocks, and ChloraPrep. Drawer number 4 includes A-line catheter sets, guide wires, introducer sheets, Swan-Ganz catheters, level 1 tubing and catheter exchange kit, and 250 cc bags of normal saline. Drawer number 5 has a trach trace, trach tubes, general purpose trace, Sonocide probe cover and ultrasound gel, sterile plastic bowl, and sterile towels and drapes. Drawer number 6 has all the hat, masks, and gowns, along with a central line kit and various sizes of chest tubes. The side door is where the majority of all line kits and trays are found. Various central lines, including Maherker, cordis and thoracentesis, paracentesis, and lumbar puncture tray. We're going to finish up this tutorial by talking about how to set up and maintain sterile field. After reviewing some of the principles of sterile technique, you will watch a short video clip from our Procedure Center nursing colleagues that demonstrates these principles. In this slide, I have outlined the critical must-dos of maintaining sterile technique. But before we review this list, I'd like to point out that procedures that require an insertion technique demand full sterile gear, that being gown, hat, and gloves, whereas procedures involving drainage of fluids, like an LP, require sterile field and gloves, but not gown and a hat. Having said that, we will focus the education assuming full sterile dress. Now, let's review the basics. First, the scrub person should function within the sterile field. That field is roughly in front of them from shoulder to waist. Sterile drapes should be used to establish sterile field. Items within a sterile field should be sterile. Be sure not to add non-sterile items, such as 10 cc pre-filled normal saline syringes from a nurse servers. All items introduced to a sterile field should be opened, dispensed, and transferred by method that maintain item sterility and integrity. A sterile field should be maintained and monitored constantly. All persons moving within or around a sterile field should do so in a manner that maintains the sterile field. This one can be challenging in a tight confines of an ICU room. The next few slides will go over the specific behaviors that represent the standards of care for ensuring sterile technique and preventing hospital-acquired infections. For setting up the sterile field, make sure that large bundles are opened on flat surfaces. No balancing a triple lumen tray on a patient's chest or abdomen. Sterile packages must be dry and placed on a dry surface. Flaps on a peel-open packages should be pulled back and lifted upward, not torn to expose sterile contents, or flipped, and not permitted to slide over the edges. Edges of packages are not considered sterile. The inner seal of the package is the demarcation of sterile and non-sterile area. Before putting on sterile gloves and a gown, surgical hand sepsis must be performed. And the RN must monitor sterile field and observe for breaks in sterility and call for corrective action throughout the procedure. Now let's review some key behaviors to maintaining a sterile field. Scrubbed person must function within a sterile field, in front of them from shoulders to waist, and never turn their back to a sterile field. Only the interior surface level of the table is considered sterile. The edges and sides of the drape extending below the table are considered unsterile. Scrubbed members must not reach over the unsterile items or areas. Unscrubbed people must never reach over a sterile field, even when offering lidocaine. Supplies for scrubbed personnel. Obtain sterile items by opening them onto a sterile field before donning sterile gloves, being careful not to reach over a sterile field, or get assistance from unscrubbed team member to set up a field. Set up cups, basins at the edge of the table, inside the 1-inch boundary to fill them. When pouring solutions into a sterile basin, the assistant holds only the lip of the decanter over the basin to avoid reaching over a sterile area. After opening a sterile solution, the contents must be discarded. No capping or uncapping. Open sterile fields must not be left unattended or covered. Removing the cover cannot be done without contamination. Now let's review movement around the sterile field. Team members that are not scrubbed must face and observe the sterile field on approach and when passing, not walk between two fields, and maintain a margin of 6 inches. Okay, we will finish up this tutorial by watching the sterile field demo from the procedure center.